As I said, I'm on the AFT Executive Council, and I don't know how long ago, but about a year ago, Mary Cathryn Richter, who's one of our vice presidents. By the way, some of you might not really understand this, but we are one of the largest unions in the country. We have 1.6 million, maybe 7 now, 1.7 million members. That is a very big union. But we are like the only union, well, probably one of the only unions in the world, to tell you the truth, to have our 3 full-time officers, president, executive vice president, and secretary treasurer, are all women. That is like unheard of almost in the AFL-CIO, and I think we should be really proud about that accomplishment. Well, Mary Cathryn is one of our top officers. She's the executive vice president. But one of the areas that she had passion around, which are many, she's a very passionate woman, but one is about making sure we had education workers, teachers and others that reflected the diversity of our community. And so she's been working on that. And she and I had a conversation, and I said, gosh, we have like probably an even bigger problem in healthcare. And so this has started a conversation within our union a little bit to say, well, maybe we should talk about healthcare also in terms of this diversity. Mary Cathryn has also done enormous, wonderful work and about the issue of the children that were coming across the border with their parents, fleeing in the south, and I know I've been down to Guatemala myself, fleeing Guatemala and El Salvador and Honduras, and fleeing for their lives, really, and then being placed in camps at the border. Well, we know now it's much worse, because now they're actually taking those children away. And Mary Cathryn has been working on this issue on behalf of our union and within the broader labor movement for a long time. And so she is she exhibits some of the best of who we are in terms of issues of dealing with the issues of equity and diversity, and making sure our union is looking at those issues. Well, in that conversation, she and Federica's coming back in, McClary, and I talked about the fact that perhaps we should put some material together or a resolution together or something to deal with the issue of education. But through the conversation, we said, you know, it's not just about creating a workforce that looks like the patients that we serve, that reflects our community. Perhaps it's time for us to talk about what is our delivery system like? How do we as healthcare workers, what role do we play in the issue of health disparities? I come from one of the most, I love the city that I live in, truly do, but the thing that I always say I don't like about my city is it's one of the most segregated cities in the United States, Milwaukee, Wisconsin. We have on a scheme of things, some of the absolute worst outcomes at all different levels, whether it's incarceration, and we, of course, you know, very famously once again in the news with young Mr. Sterling Brown. And so we have a terrible policing problem, incarceration, police, but we also have some of the highest infant mortality. And so we're very active in a national union and a local union on the issue of Black Lives Matter. But there you step back and say, okay, there's something more than incarceration if you care about Black lives. There's also everyday Black lives and everyday lives of our entire community. And this was driven home again to me, and I mentioned it yesterday, but I think it's still worth mentioning, that in our city, the largest health system, which has tremendous resources, decided that they would close the inpatient units at a hospital in an area of town that's primarily African American, and they would then open inpatient units, you know, miles across town in the primarily white area of town. And when we confronted them on that and said, well, how will people get there? You have an emergency room. And they said, well, they hadn't thought about that. Well, I guess what do they do? Get on a bus? If they got a heart attack, you put them on a bus, you go around town. So we were, even in this work that we were doing, suddenly confronted with the fact that this city of mine it was so brain dead that it didn't realize how bad this was. And to our credit, together with our community, we immediately stood up and fought back and raised holy hell, to tell you the truth. And I got to say, I was shocked that we were able to get Ascension, this huge health system, to step back and completely change their position and said they will leave these units open in our city. So that's the kind of work that we can do together, and that's part of what we're doing about this fight. So we have a great panel of folks that are going to talk about this issue from their personal perspective of the fight that they're doing over the issues of health equity. I said, you know, it's quite amazing to think about the fact that it doesn't matter what your insurance is. You can be really well insured, but racial and ethnic minorities still have worse outcomes. So it's not about getting everybody insurance. It's something far deeper, and that's what we're going to talk about today. So I'm very proud that Mary Cathryn is here to lead off and moderate our panel, and I'm proud to work with her on the AFT Executive Council. Mary Cathryn Richter from where I was born and raised, St. Paul, Minnesota.
Thank you so much, Candice. I really appreciate that. It was a nice way to set the stage from an actual practitioner in the field. The first thing I will just remind folks of is I am a middle school English teacher by license. And so nursing and healthcare is not my profession. I am here as a fan, as an advocate, and as a learner, as someone who spends as much time as possible learning what the conditions are for nurse and healthcare workers and understanding how to best support them. And because our union has an incredibly strong commitment to the people we serve as well, understanding of the most urgent conditions our nurses and healthcare practitioners would like to address so that you can better meet the needs of all of the patients you serve in the community you serve and the community you live in. We're going to take a moment to introduce the panel, and what I've asked them to do is introduce themselves so that so a couple things can happen. One, you hear the most relevant experience that will really pertain to the topic of how we as union members will take a leadership role in reducing disparities in healthcare and in our healthcare professions. And I've also asked that certainly if there is particular professional expertise, they want to make sure you know that if they would share that. And also if there is a personal experience in healthcare, since we have a really esteemed group of folks with us, that you also hear that, because one of the things, as we spoke over lunch and as I spoke with Candice and with Anne, we understand that nursing and healthcare is very relational work. You take the expertise you have and you partner that to the relationships you build with the people you serve, and that's how you provide the best care possible. And so we know we have a limited amount of time with you today, but we'd like to make sure we tap into that partnership you offer in that relational piece of your work, coupled with the expertise both in this panel and sitting in this room, to make for a really empowering session, so that we leave here thinking of how we as union members will take leadership in eliminating predictable disparities in healthcare and in our healthcare professions. So with that said, let's start, if you don't mind, starting at the far left and coming this way. We'll do a quick introduction and then I will jump into questions.
Hello, everybody. I'm Alysson Hilliard. I am an OBGYN hospitalist for Kaiser Permanente here in the Northern Virginia, DC, Maryland area. And I am passionate about this particular topic because I am on the front lines of this on a day-to-day. As an OBGYN hospitalist, I am the person that pregnant women come in to see and get triaged and then go to deliver their babies. And so I'm one of those physicians that sees them first and has to make an assessment as to, what's going on with them. And in addition to that, I'm also a Black woman, as you can see. And so it is very near and dear to my heart because this is me. I potentially could go into anybody's hospital and potentially not come out, and that's a problem. And me even being educated and having, being in a higher socioeconomic status, I still have the same risk as those who don't have the means and was blessed as I do to have the insurance that I do. And so again, that's a problem.
Thank you. I got it, yeah, thanks. Good afternoon, everybody.
Good afternoon.
How y'all feeling? Good. Going after lunch, I could take a small siesta, so I'm trying to get myself hyped up right now. Figure I'd get y'all involved. So I am Joia Crear-Perry. I'm an OBGYN by training as well. I am the founder of the National Birth Equity Collaborative, but I'm also on the steering committee for the Black Mamas Matter Alliance. And our goal is to reduce the disparities. Our vision is that every Black infant live to their first birthday with their family, right? And so considering that 3,500 Black babies die a year in this country, that's a very auspicious goal. We are excited to be a part of this conversation. I was excited to learn that you all are not are nurses inside of schools, but also in hospital systems, because so much of this occurs inside of hospital systems, as was mentioned. And the one thing to take away is that health inequities and health disparities are not created by individual choice, right? We spent a long time trying to prove that there was something genetically different, or God put us on different continents, and so therefore we have these outcomes, that we've completed the entire Human Genome Project, and we're all the same. And so we do know that this country was founded on a belief that both women and people of color were not fully human. So when you have that embedded in your history, it's how you play out within your laws and in your culture and in your TV, that belief still exists. So in order for us to end inequities in our hospital systems and in our culture, we have to start with this understanding of this is what we believed, we know it not to be true, so what are we gonna do to address that? I have with me today my sister and my son, who is 22 today, yay!
Happy birthday.
And when I was in medical school, after I was going to Princeton and started medical school, in my third year medical school, I went into labor with my son. He was due in October, and he came today. 22 years ago, yeah. He weighed 445 grams, and he NICU nurses in the house, so he wasn't quite a pound, yes. And my mother called my sister, who was at Georgia Tech, and said, my sister's gonna die, baby's gonna die, we're all gonna die. So she left school, was panicked, right? So I had no risk factors, right, except for my Blackness. I was married, I was educated, I come from an educated family. So knowing that how we are treated, not just inside of hospitals, but all the time in this world, creates a space where our bodies are revved up all the time, makes us have babies early. So until we stop making us have the impacts of racism on our bodies, we're going to continue to have that happen. So we need all of us to work on that together.
Well, I'm glad they went first. I'm a little nervous. So my name is Angelina Wyatt-Jolly. I am a registered nurse. I currently work as a psychiatric nurse in our crisis services department, and as well as emergency room nurse. I'm from Milwaukee, Wisconsin, where Candice told us about, where in Wisconsin we kind of experienced some of the biggest disparities in healthcare amongst African Americans. And I grew up in a neighborhood, the 53206 neighborhood, where the majority of my family still resides in, and we have some of the widest life expectancy gaps between African Americans and whites as well. So understanding that and working in the clinic and as well as the emergency room, I interact with African Americans on a daily basis, where I educate, I talk with regarding how to improve life and health outcomes. So I'm here basically as a voice for the people. Try to understand and bring attention to racism in the healthcare field, both on a professional level as well as being a patient, and how can we improve those outcomes in Wisconsin.
All right.
Hello again. I hope you all had a good time yesterday after the first plenary. And I'm really glad to see more of you are here, so I guess all that weather issues with travel resolve themselves, right? My name is Sinsi Hernández-Cancio. I'm the Health Equity Director for Families USA, which is a nonpartisan, nonprofit healthcare advocacy organization that's focused on achieving the vision that every single human being in the United States have access to the best health and healthcare possible. Before that, I guess relevant experience is that I do come from originally the labor family. I worked at SEIU Healthcare for 5 years, including during the time when we were trying to get the Affordable Care Act passed, and specifically working on the part of the campaign that was trying to speak to the needs of communities of color and trying to get issues around communities of color embedded into the Affordable Care Act beyond just getting people insurance. And the other, I guess, area of expertise is that I have, my first policy job was working for the two governors of Puerto Rico. And I do want to recognize again those of you who actually went and volunteered after the hurricanes and remind people that, you know, on the heels of this news that close to 5,000 people died in Puerto Rico post-hurricane, mostly because of lack of access to health care, that hurricane season started 4 days ago.
Yep.
And there are still about at least 16,000 customers that don't have electricity yet in Puerto Rico. And that is, customers means like units, so each customer could be a family of 5 or 6, could be a business. So, you know, just please keep that in your hearts and in your minds as this summer develops. But the one thing I wanted to share with you about, I guess, a relevant story, and I have many a healthcare story for me and for my son, but I want to share when I figured out that health disparities based on race existed. And I was 4 years old. And my father, que en paz descanse, was training to be a doctor. He had graduated from University of Puerto Rico and ended up in Springfield, Massachusetts in the early 70s to train. And I remember him coming home one day super angry, like just yelling and screaming. And so the reason I know I was 4 is because I know when he was doing this internship, right? Yelling and screaming about an experience he had had. He was rotating in the ER. And he had noticed that the Puerto Ricans in Springfield, there were about 30,000 Puerto Ricans there, never got the actual doctors in the ER, only got the students. And so he had the audacity to ask his attending, why is this happening? And the attending actually answered, oh, well, you know, those are the ones we practice on. And so, understandably, he was very angry, and that's what he took home. And imagine being a 4-year-old girl with health problems and hearing that this is what's happening to your community, that people in power, people who hold life and death in their hands, feel like it's completely normal to say something like this, not behind closed doors, but to the face of a doctor in training. From that community. So I guess you could say that kind of like marked me for life, because this is what I do today. Along with the fact that my mom was una promotora, working with farm workers, who were teaching them not just, you know, hygiene and health issues, but teaching them to read. And that, I guess the one thing I want to start off this conversation with is that I want to challenge the premise of the goals that have been stated, that we need to change health care to make health care less racist, basically. But we also realize that the reason that stories like what Joia was talking about is not necessarily because of things that happen inside the clinic or the hospital. It's because of the load that many of us have to deal with on a daily basis outside. So figuring out how you partner with community to address this outside of just your profession, which is extremely important, and outside of just your clinic or hospital or the school you're working in.
Thank you so much. Thank you very much. So we, in talking with Frederica just about the time frame too, we definitely want to get to questions. We assume that there are going to be ideas percolating across this room. We also don't assume your ideas will stop percolating at 1:30, but we do want to make sure there are questions. So I'm going to share just a few key terms that are going to be our working definitions for this session. In your workplaces or in other places where you perhaps are doing this work, you may have other working definitions, but the panel and I have talked about this and want to make sure that when we are using terms, you understand that they are they have some things in common for us. So if you look up on the big screens, you'll see that for this panel, and we'll hopefully talk for about 30 minutes. And then open it up for about 10 minutes of questions, and then we'll close with any sort of closing thoughts or really sort of closing calls to action we have for you that we'd like to offer. So with that, we'd like to make sure that as our operating definition of racism for this panel is going to focus on, is going to center around power. It is hatred and bigotry based on race and belief in a superiority of race. We are going to also be using the phrase implicit bias. You have likely come across that phrase in many settings. For us, we are going to talk about bias that is implicit and an implicit aspect of prejudice, and it is an unconscious activation of prejudicial notions of race, gender, ethnicity, age, and other stereotypes, right? And then harm, as we talk about harm on this panel, we are going to talk about both actual and potential ill effects, which is caused by a particular course of action. And of course, part of this panel will be exposing what those courses of action will be so that we can interrupt them or end them, right? And then you will likely hear us talk about this concept of whiteness. And that is, again, it may be something that you have come across before. For us, we are talking about a system that socially, economically, and ideologically benefits European descendants. It is about skin privilege, and then other research to determine social factors that influence the health of people perceived or actually white. So we can come back to those key terms if you need them for anything, but I just wanted to start there so that as we share those things, you'll understand. I'd also like, before I throw my first questions to probably, Dr. Joia and Sinsi, we may start with the two of you for the first question. But before I do that, I just want to offer a couple things too. Like I said, my experience has been in education. And so I am here very much as a learner. But what I'd like to offer you to consider is that in my experience in education, as Candice pointed out, trying to determine how we can better recruit and retain educators of color and Indigenous educators, realizing that where we have been starting is that educators have largely become typically white women. And so if that has been true over time, one of the questions I ask myself about interrupting the predictable disparities in education has been, how has education over time then been normed for and to white women, right? In the way that we recruit, in the way that we train, and perhaps even in the way we teach and evaluate teaching and expect learning. So, when I ask those questions of myself in education, then the next, and as I look for answers with my fellow practitioners, I ask then, therefore, how do we interrupt that norming, right? How do we correct that? And so I would offer to you the same wondering, right? If right now nursing and some healthcare professions are largely white women, if they are, then has nursing, or the practice of teaching nurses, or the expectations put on nurses, been normed for white female nurses? And it is a wondering as you look at the landscape of how your profession has been constructed, how people get recruited, how people are retained, et cetera. I offer as something that may be useful to you. And so, and we're here because there are people in our community who see this as a non-issue or don't realize this is an issue. And we're here because we have actually noticed the issue, and we're part of a union that says we can actually do something about this. We don't just have to see a problem and admire it, right? Like, whew, that's a really big problem. Yeah, look at how big that problem is. Yeah, that is a really big problem. You should see the problem from my angle. That is such a big problem, right? We can actually do something about it. That's the very foundation of unionism, right? We work collectively to improve people's lives. Now, amidst that work, historically as a union, we know that sometimes this work makes people uncomfortable. But we stay in solidarity, we stay in discussion, we stay in relationship, and we work through it together, and again, we offer solutions. And so you can tell I am joined by this amazing panel of experts. They have gotten background on you to understand the expertise you actually bring to the field of healthcare as well. So we really anticipate this being a dynamic discussion where we dispense with just admiring the problem, we name it, and then we spend a lot of time offering solutions. And again, incubating those ideas for how can my local union, or how can my state union, or how can our national union actually do something about predictable, disparate outcomes for people of color and indigenous people in our healthcare system, right? How does this impact recruitment? How does this impact retention or advancement of people of color or indigenous people in our work? We really hope that you will leave with a greater understanding and the intentions and the support we are offering to you of what you can do to take on these challenges in your local or in your state and in our professions. So first, to give context and create a mental picture, I would love for us to start with our panelists. And so, Dr. Joia, would you start, and then I'll ask Sinsi if you would also, just given the expertise of your background, would you start with what does the landscape look like for a moment, and just, again, kind of frame that problem for us?
Yep. So, as I mentioned, our organization works on both Black infant and maternal health, and as you know, for infant health, most Black babies die at about twice the rate of white babies in this country, and for maternal, it's 3 to 4 times the rate. I heard New York's in the house. We have New York folks in the house. There we go, yeah, so y'all are 12 times the rate. I don't know if we should get excited. For maternal mortality, yeah. So I get to do a lot of work in places and to really dig through what that really means, right? Like thinking about if we believe that we're all start off kind of as equal human beings, how could we get to this place where we have these disparate outcomes? And it's important for us to think about our role in that space. So when you have a framework around human rights, which the United States was not built upon, right? So when you have a human rights framework, which other countries are, so the countries that we love, who all heard about the baby boxes last year? Like, I was on so many baby box panels. We're gonna get a baby box that's gonna cure safe sleep and everybody's gonna be happy. The truth is, the reason the baby box works is not because of a box, but because they have paid paternity leave, not just maternity leave. The dads get to stay home too, right? They have free college for everybody, right? So we love things in the United States. We like to buy boxes and breast pumps, but we don't invest in people. So the countries that have a human rights framework actually invest in people. So the countries, the places that Black infant mortality is bad and Black maternal mortality is bad, white is bad too. It's just better than ours, right? So if we were actually to invest in people and have college and have paid paternity leave, our landscape would look a whole lot different. And so what the beauty of having a union is that we can fight for those kind of things. We end up fighting each other about things, and who wins is the folks who don't really need these resources, right? If you can buy your way out of this, pay for education, pay for school, then it's an irrelevant moot conversation. But for us, the rest of us who really need there to be a baseline that we can survive off of together. It's important that we invest in infrastructure. We shouldn't have to fight each other about these kind of things. So anyway, the countries, most of the places that have bad outcomes are in the South or in the Midwest. But that's still, even the places like California or Massachusetts, who have really invested in some of those things, their outcomes are not as good as some of the other countries because we still don't invest in a social safety net the way that other countries do. So that answers the question, yes? Okay.
Yeah, thank
I
you.
wanted to add something about, and I can already tell you that we're going to make this a lively discussion, because I like pushing back on concepts. And I think, on the one hand, from the perspective of the daily work that all of you do, understanding interpersonal racism and implicit bias is extremely important. But I also think that at the end of the day, when we're talking about these issues of what the landscape, gives us and what is out there in terms of social investment, and the realities that people face every day, the kind of racism I'm most concerned about dismantling is what we'd call structural racism and institutional racism. And that has nothing to do with anyone's feelings.
Right.
And I think it's important to point that out, because a lot of people will say, like, well, I don't feel that way, so it's not my problem, right? We can admire that problem from far away. But the truth of the matter is the fact that there are these enormous disparities by zip code in such we are incredibly segregated country, actually. People think, oh, we've moved on from the 60s. We're actually more residentially segregated now than we were in the 60s. And when you think about how things are paid for and who makes decisions about the distribution, both of resources, not just healthcare resources like hospitals and clinics, but also health resources like water that's not poisoned and air that doesn't give you asthma and emphysema, and food that is healthy, and neighborhoods where you don't have to be in the fight and flight response all the time because of violence and all sorts of other issues, then you realize that doesn't happen by accident. That happens because of the accumulation of decision after decision after decision of who gets resources and who gets dumped with risks. And that is why, we mentioned this a little bit yesterday, but that is why picking leaders matters. That is why elections matter. And just because you aren't a racist, it does not mean that there isn't an immense amount of work that you can be doing to level that playing field. And I don't know if it was up or not, but there was like an image that we use a lot about the difference between equity and equality. And it's all about, equity is everyone getting what they need, while equality is everybody getting the same thing. And we know very well that because for so long, generation after generation, everybody has not been getting the same thing, there needs to be a redistribution where people get what they need to be able to thrive. And I can go on later about why this is so important at this moment right now in this country. But I want you to hold in your mind that there are these two things that we need to address. The interpersonal racism that people deal with every day, but also the structural racism, which is about the power to decide who gets what and when.
Thank you so much. Dr. Alysson, do you want to add some context to that, or some of the...
I guess you mean from like a standpoint of on a day-to-day?
Yeah.
Yeah. So context would be that everybody has their own set of glasses that they see the world in. And I think that where we really, really have to start is that looking inside and seeing how you see the world, and then how you see people, and then how you take care of people. So if we start with really looking at ourselves and saying, okay, how do I see this person that is in front of me that looks different from me, and taking off our glasses and putting on their glasses, I think that we could help this problem. Because on a day-to-day, when we're seeing patients, we're inundated with patients and taking vital signs and making sure and trying to get through our day. And so it's really easy to just keep our own glasses on and see the person how we see them, as opposed to seeing them how they really are. And does that answer the question, I think? In the context of, like, we just have to really try really hard every day when we're taking care of somebody to really see them for who they are and not through how we see the world in our glasses.
I think that's great. I think it's a great analogy to actually leave this room with, too, because that's something we can carry with us as something we can practice every day. Angelina, you've had 18 years of experience in the healthcare industry, including the last 4 as a registered nurse. And you and I last month had actually an opportunity to have a conversation with a larger group of people about experiences and your witnessing of inequities in the healthcare field. Again, as part of adding context from a nurse's perspective and from your experience, would you like to add some context again from the expertise you've had in this career in healthcare?
Over the past 18 years, I've had the opportunity to work in various positions, from a CNA to a unit secretary to a registered nurse, and then also in various settings such as clinics, hospitals, home health, you name it, I probably done it. But most recently, I guess what I noticed the difference is I've lived in Arizona for a short time, and even though the population for African Americans in Tucson, where I was less than what I'm used to in Milwaukee, Wisconsin, I experienced less discrimination as a healthcare provider. I had patients who lived a very modest life, and then it's when I come to Milwaukee and working in the inner city, I experienced more prejudice, one amongst my own people, and then as far as in physicians and healthcare professionals. I work in a profession where the majority of the professionals are white, and then the majority of the patients are black. So in this clinic setting, I just recently experienced a physician inform a patient that he was going to report her to the state without even knowing what her diagnosis or the outcome of her testing was. So at that point, she was very appalled and wanted to report this physician. But it's so many times that I encounter these incidents, and then I'm left to kind of explain and break it down to people like, this is not what he meant this, or providing education or how to prevent preventative care and stuff like that. So it just seems like there's a lot of subtle bias and prejudice in dealing with people of African American descent in the inner city, and I feel like there needs to be some type of action or policy in place, a culture competency. Even though most healthcare providers are required to take a culture competency class, I think just clicking on the mouse and going through the presentation is not doing anything. So I did eventually went to this the physician supervisor, and I don't know what the outcome was, but I can tell you it really wasn't any changes, because I continued to work with this physician. It was pretty much like the same thing over and over. So like I said, throughout my experience as a healthcare provider, I'm frequently experiencing these. And especially in my area right now, I'm trying to bring about a voice. Like, how can we stop this? How can we improve, like I said, the African Americans' expectancy?
Thank you.
Can I add
Go, Sinsi.
some?
Absolutely.
I think one of the key things that I learned about organizing and advocacy is that it's important to marry a good story, or a bad story in this case, with statistics. And I'd like to share really quickly some very recent information about the experience of discrimination and bias in getting health care. Earlier, at the end of last year and early this year, NPR, the Robert Wood Johnson Foundation, and the Harvard Chan School of Public Health did a first of its kind survey on people's own experience, not their opinions, but their own experiences of discrimination in a whole wide variety of things, from education to jobs to the criminal justice systems. And it also included 2 questions on healthcare. So people were reporting what they had experienced personally in terms of discrimination in getting healthcare because of their race or ethnicity. And even for someone in my line of work who knew this existed, I was shocked to find out, for example, that 1 in 3 African Americans reported that they personally had experienced racial discrimination trying to get health care. And 1 in 4 Latinos, 1 in 5 Latinos and 1 in 4 Native Americans. They also surveyed, just to round it out, LGBTQ folks, who also said, you know, they had experienced, 1 in 6 had experienced discrimination getting health care. But what is even more troubling is the next question they asked, which was, have you avoided getting the health care you need because of fear that you're going to be discriminated against and mistreated and humiliated? I mean, those last 2, those last 2 adjectives are mine, but that's what it's about, right? And 1 in 4 Black people said that at some point in their lives they had simply not gone to a doctor or a hospital because they did not want to be discriminated against. And so imagine what that means. And imagine, and similarly, you know, 1 in 5 LGBTQ people and Latinos, and 15% of Native Americans, 10% of Asian Pacific Islanders. So think about what that means. And this is inside the walls of a healthcare provider. And what can be your role to turn that around?
That's right. Yes.
Of course, I feel like me and Sinsi could probably take over. We're not going to do that, though, right, Sinsi?
Right.
No, but to add to that, how that plays out in our bodies physically. So there's some data that shows out of UCSF that for Black women who, despite income, so despite being, you know, having a higher education, the higher that you said you felt racially discriminated, it also correlated to your prematurity rate of your infant, right? So that's why it doesn't matter your educational status. When you control for feelings of discrimination and feelings of having experienced discrimination, not just in your healthcare system, but in work, you are higher rates of having prematurity. And so that's why it's really important. We need to unpack for sure all the structural ways. And I'm going to give you a concrete example of structural racism that you might not think about because it's well-intentioned today. Anybody here from Missouri? No Missouri folks. Okay, well, so Missouri right now is
So we can talk about them
I
because
can
they're
talk
not
about
in the
them
room.
really, really bad. No, no, I'm working. I love Missouri. Yay, Missouri. No, but they're planning to do a Medicaid expansion bill, but it's just for opioid-addicted mothers. Right? So think about what that means. And they really are well-intentioned with it, right? So they're like, we're so excited, we have this great big problem. I said, close your eyes and imagine what that's gonna look like 10 years from now for the crack-addicted mothers, or for the mothers who are addicted to other things. Like, how did you pick this one demographic to do Medicaid expansion for? So yes, their health outcomes are going to improve, but what have you done for everyone else? So when you choose based upon your belief of a value, of human value based upon skin color, that one group should get something that another group doesn't get, that is racism. That's what that is, right? And so and the man who, I said this at the last meeting I was in, and the person who created the bill was in there. He said, I didn't even think about it. And that's the point. He wasn't trying to be mean. He just innately has a preference and a bias towards people who look like him. I get it. You know, most of my friends are Black. So, you know, I understand how we get to this space. He actually has power, though, to create laws that then cause this huge inequity inside of health. And so what we have to all learn how to do is value everyone, and to believe that everyone has value, and to ensure that we don't create a law that's going to further an inequity further down the line.
Just make one comment.
Yes.
Because if we don't, what will happen is the world will be one race. And what is a world like with that? And that's why you have to buy into this isn't just our problem, this is everybody's problem.
That's right.
And again, to go back to your point of you can't just look at the problem from afar and be like, oh my gosh, look at that problem. Sorry for them. No, because what will end up happening is there will be no African Americans, there will be no Hispanics, there will be no Native Americans, there will be a world of all white people. And as wonderful as white people are, do you want a world with just one race? No. Just like I wouldn't want a world where there's just Black people. So that's why this is like really, really important.
Angelina, yeah.
Oh, I just wanted to mention, because Dr. Joia, you stated that in Missouri, where they allocated all this money to the opioid crisis, Wisconsin, we just had something similar. I don't know what the exact dollar amounts were, but the state received a grant for X amount of dollars, larger than any other group of health care reform. But it was to go to opioid, where Wisconsin is dealing with one of the highest teenage pregnancy rates, one of the highest incarceration rates. They're constantly reducing money for education. And then we're in a mental health crisis. Right. So no money was allocated to these programs or resources, but we're allocating money to opioid crisis, where most people have control over. So where we're affected in the categories where we're dealing with historical trauma, dealing with the African American issues, no one is allocating money to these programs. Therefore, it's increasing these gaps with life expectancy. Like I said, my neighbor, I can be on one side of the street, and neighbor can be on the other side of the street with a different zip code, and they have a 20-year life expectancy greater than I do. So where do we come in to play fighting and speaking up for how these dollars are allocated?
Thank you. I actually think all of their comments lead to what I believe is a great transition to also a very helpful way of thinking about this going forward as we think of the role our union can play in addressing predictable disparities in healthcare outcomes. And that is, everyone in the room is likely very familiar with the term or the idea of social determinants, especially in research. Right, as we research the impact of biology and genetics, or individual behavior, or the social environment patients are in, or our community is in, the physical environment our communities are in, the health services and access, right? As we research these social determinants and we then change our practice or improve our practice because of what the research says, that is also parallel to the conditioning that we may have received, or our systems may have adopted as part of the communities we are in, right? So conditioning to perhaps implicitly believe that people of color just aren't as fit as white people, right? Or that Native Americans just don't take care of themselves as well, right? These are conditioning factors that exist in our communities, or exist in our society, exist in our circles of influence, and they can then often be used implicitly as excuses for why these outcomes are so predictably disparate, right? Or why an ailment such as diabetes, or high cholesterol, or blood pressure is more present in one community as another. But actually, Doctor, you have a very different take that I think is very enlightening, and also very helpful to, again, agitate a union in a really affirmative way to, like, here's how, if we reframe this, here's how we can actually be in a position to think about doing something differently. So would you expound on that for us, and this idea of social determinants?
Yeah. So first we started using the term social determinants of health inequities. Because it's important for us to realize they don't just pop up, right? Even when we mention this idea of the neighborhoods and the zip codes, they weren't made because black people just like living next to each other, right? There's a thing called redlining. Who's heard of redlining? Yay, it's important to hear redlining. So the federal government created slums. That's the bottom line of redlining. You can read about it later, but just know that we didn't just all decide to live near each other. So when you think about social determinants of inequities, they come from root causes. So you have 3 root causes in the United States context. If you were in other countries, it could be others, but usually we talk about racism, classism, and gender oppression. So all 3 of those things cause us to have the inequities that we have. And so unless we work on racism, classism, and gender oppression, we're gonna keep having life expectancies in the same, across the street from each other. We're going to keep having higher rates of hypertension because we haven't really gotten to those root causes. And so that's something we have to do collectively as a country. And even the opioids, I would tell you this, that this idea of whiteness, when we think about what it meant, what it means to be white, when it actually, I come from New Orleans, which is a place where whiteness was not only inside of the government, but Creoleness, right, was a thing. Like in law, you could buy stuff because you were Creole, you could own things, you could go to school. So we created a caste system in this country based upon our skin color. We created a hierarchy where you could buy and own. So as that's going away, what do you get for being white? What is your value of this whiteness? You can't buy a building because you're white now, right? So this idea, there's some data out of Harvard, the health effects of whiteness and this belief of a meritocracy. So think about this. White men are 12 times more likely to commit suicide than black women, right? 12 times more likely. Why is that? It's important if you don't have a redemptive narrative, if you believe you're supposed to have everything at all times and that you're never going to fail and that life is always upside, guess what life does? It shows you that that's not true, right? That you don't get to have everything. And so that's a despair. This idea of racism is killing all of us. It's killing black people, it's killing white people. This idea that we are supposed to just have because we're white and that other people are not supposed to have is making us vote against our interests. It's making us take drugs we're not supposed to take. It's killing us all. It is a fallacy that we have this hierarchy based upon skin color. We are all individuals. We're all in this together. And so the social determinants of health are really a space that we can work on racism, classism, and gender oppression, that we can work together to improve all of our outcomes.
I see lots of heads nodding, so I like let folks jump in as they can to react to that.
It's the importance because I think sometimes people hear the word racism and they feel either guilt or they feel nervous or anxious, and that's not what, it is a historical and a current fact in this country. These are words and language that all of us should be able to say very freely, that we wrongly believe, we had a structure that believed in a hierarchy of human value based upon race, and it hurt both black people and poor white people and Native American people and Hispanic people and all of us, right? Women, all of us. This belief of you should have based upon these physical characteristics, and none of that is true. Yeah.
So the thing about it is that we have to acknowledge it,
Right.
in order to we can't just sweep it under the rug. And that's what we've been doing for years and years and years. We have to acknowledge what happened. It happened, and it was bad, and it's still bad right now. And the more we sweep it under the rug, it's just going to get bigger and bigger and bigger until it's going to explode. And so yes, and we have to also take it from the context of it doesn't just affect, racism doesn't just affect the minorities, it also affects majority too. So that very well said.
So I have two things I want to say about that. And the first one is that it's easy to say, well, that happened a long time ago. Why do we care now? And as I said earlier, there's the policies about who gets what and when, and who gets the good stuff and who gets the bad stuff, are still grounded in, for a variety of reasons, longer than we can even talk about here. But they're still grounded in this hierarchy idea, right? And then the other thing is that if you look at where it affects all of us, and it's going to affect all of us even more, if you look at and I touched on this a little bit yesterday, on where this country is going in terms of demographics.
Yes.
So you're going to get at the same time the graying of America, where by I keep saying 19, by 2035, there will be more seniors and children in this country, and that has huge implications on who pays the Social Security, what our economy looks like. And you're going to have, majority minority, so to speak. And if you're a majority minority nation in a country that doesn't, and your workforce is majority minority in a country that still does not value those lives and invest in the success of those lives, then who the hell is going to be left over to take care of those that graying generation? And what's going to happen? And at the end of the day, our healthcare system is going to collapse under its own cluelessness, right? And so you all have a strong role you could play in that space. And especially, I remember once I was talking to young people, young invincibles, right. And it was a room majority, mostly white young people, very committed to equity and justice, and they wanted to know, what can I do beyond just feeling guilty? And I said, well, just remember you know, like Batman, white privilege is a superpower.
Right.
Yeah.
And with great power comes great responsibility. And so there is a lot that can be done from people in your positions that will sadly be listened to differently than people like at this table, despite our Ivy League degrees and whatever, right? And so the first step is you with your superpower, you know, not just speak for us, but speak to say, you need to make this table bigger and you need to bring in these voices. Because on our own may or may not work. So I think there's a lot to be done within your institutions, but especially within your communities, to reach out so that you can hold space and create space with your superpower so that others who really need to be part of this conversation, who can't have policies made about them without them, be part of that policy making, you know, that national and state and local dialogue about who gets what when, because that's the only, good intentions are not gonna change this. There needs to be resources allocated.
Thank you. We are going to move to questions from you for our excellent panel. And as we do that, you can see there we have a couple microphones handy. Angelina, I would love it, as folks are getting ready to ask questions, as an AFT leader on this panel, and we've heard about why this is the right thing to do from lots of vantage points, right? Why is it, for you as an AFT leader, why is this also the smart thing to do, as well as the right thing to do, as we're talking to our fellow members here?
For me, I think it's the right thing to do because a lot of people go with the notion that if it doesn't affect you, then why speak up? So for the people who can't speak, or even the people who can speak, I feel like it's my duty, my professional duty to bring awareness to the situation. I mean, segregation, unfortunately, will probably be around for a while, and it'll vary depending on where you at and where city you at. But I think being in my current situation where I'm at, there needs to be a voice in politics, as well as in our community, about how can we better ourselves. And I'm not really the quiet one when something really bothers me. So like I said, I have a passion and to speak up for people, like on a professional side, as well as a patient, to bring awareness to disparities in my area.
Thank you. Thank you. And you are speaking to a room full of leaders, fellow rabble-rousers, so that's wonderful. Let's start with a microphone here, and then we'll look to see who you find next, and then we'll bounce back and forth.
Thank you. My name's John. I'm from Michigan. Unfortunately, Michigan is the home of the Flint water crisis.
Right.
And it was a fairly dictatorial process of disenfranchising that community where a financial manager had the authority to change the water source from the Detroit system to the Flint River, which caused the calamity, the crisis. That still carries on today. Recent reports believe that several people died from Legionnaires related to that, as well as scores of miscarriages, in addition to the lead poisoning of so many. We also hold the unfortunate distinction of the city of Detroit having anywhere between 40 and 50,000 households without water because of an archaic way that the city collects its water fees. Many households had no control over that because their landlords possibly didn't pay their water bills. And currently we're facing in Michigan a work to, in order to get Medicaid expansion, and coincidentally the regressive legislatures have a waiver that's sophisticated that rural communities that are mostly white will get a waiver, whereas the other communities that are predominantly black will not get that waiver. That legislation hasn't passed yet, but it may pass. This is only meant to complement the question of health disparities. And I know that we know that racism precedes the present administration. But at the Michigan Nurses Association, we have taken on Trumpism head on. Last year, we had a floor battle at our house. The title of the resolution was to defeat Trumpism, and it was a battle. But I'm glad to say that 2/3 of our House delegates, the highest authority in our organization, supported that. This upcoming House, we are going to have at least 2 resolutions, one to support the rule of law, and we now know that Trump's lawyers and Trump are trying to believe or put forth the assertion that he is above the law. We need to confront that directly. And the democracy is in peril. And the other resolution that we're going to be considering is to take on hate. And that's the biggest threat to the labor movement right now. So I know I don't have a question, but that was just a comment.
Yeah, thank you. No, but thank you for that. And I just want to respond to that because you gave great examples of both how people use racist ideas to make money and to keep power, right? So by separating out the rural from the urban, you then use this racist idea to keep your rural political power because it's the same, you got, they make the legislature so you have enough votes to keep power that way. And then you also make money off of Flint, right? So you use racist ideas to say, well, we can't afford to make the water clean for folks and we don't care about those folks anyway. But both of those things still both impact white and black people. Right? And so it's still these ideas, and we're both dying. Michigan doesn't have great rates for any of these things for white or black people. So that they are able to use these ideas to make us fight each other, and then we both suffer.
That's right. That's great. Thank you. Got
First,
another one here?
thank you for this discussion, and I cannot say how grateful I am that AFT is going to begin to take on the lack of diversity in nursing education. You asked for stories. I have a story. And I still carry that with me, and every chance I get to speak on it, I do to those who I think can influence. And so my question is, I want to know how we see that going forward. Is NYSET involved? And you can think about that while I share with you my story. As a master's prepared nurse, I'm very concerned about the lack of representation in the nursing field. The last time I looked at the numbers, oh my God, for Latina nurses, less than 1%. And for black nurses, less than 5%. For most of my career, I've been the only black nurse in just about every setting that I worked in. For the first time, I'm working in a setting where there's quite a few black nurses, and I love that. But that is not to say that white nurses aren't doing wonderful work and are extremely culturally competent and sensitive in their heart and all of that. In fact, one of those nurses is the reason I became a nurse. But with that said, you cannot minimize the value of cultural experience, lived experience. That needs to be part of the mix. When I worked in higher ed at a community college, I couldn't stay there because I was too far removed from intervention. But for that time that I was there, I began to realize that the attrition rate for the students of color was mad bad. Okay, it was like more than 5 times that of the white nursing students. So, thinking that I was a faculty member of equal value and could speak at the faculty table, I brought this up. Oh boy, it was not received well, and I was not received well by that faculty at all from that point on. And the reason was our culture of attainment, our culture of capitalism, of elitism, especially in higher ed, it happened to be one of the nationally acclaimed associate degree programs in the nation. But you know why that was? Because they were weeding out any of the students who had any difficulties to keep their numbers high. That was horrible, and when I spoke on it, there was never a response to it. But before I left there, I called the SUNY chancellor, and I showed him the data. I let him know the efforts that I had made to even talk about it, to begin to strategize around it. Fortunately, the SUNY chancellor at that time was a black male. He said, Julie, I can't save you in that system if you're not tenured. Nothing I can do. But I tell you what I can do. I can make sure that things change and that something happens and that it gets looked at. Okay? So I'm grateful for that. But something has got to be done. Nothing much, has changed nationwide in terms of diversity of faculty and success of nursing students of color and supports and incentives and that sort of thing. So is NYSET going to be in on this too, or is it just AFT, and what do you foresee happening? Because I'm so excited about it, I want to be a part of it.
I think you will be. I think furiously taking notes right here. And absolutely, when we say AFT is going to work on diversifying the profession, it can absolutely only happen with our state affiliates like NYSET and with local affiliates we have in the room. Because that's where, again, those personal conversations are going to happen. That's where the best recruiting strategies are going to come from, quite frankly. And again, I apologize for any reckless transference of my experience in education applied to healthcare, but when I was working on what our best solution would be for diversifying the teaching profession in St. Paul, the first thing I did is I interviewed the teachers of color and Indigenous teachers we already had and said, what attracted you to the profession? What did you find value, what did you value about your, how did you get recruited? How did you get trained? What keeps you teaching, meeting the needs of St. Paul students? And that really shaped the program we wanted to come up with. I think we can't, the first thing we have to do is we can't treat our healthcare professionals of color and our Indigenous healthcare professionals who already exist like you don't exist. Right? We have to understand what brought you to this profession, what keeps you in this profession, what experiences did you have that almost made you leave the profession, right? So what, the sort of the opportunities and barriers you uncover are going to be very influential in shaping what we do. And oh yes, thank you. While we have amazing, generous experts in the field who also are willing to be tapped, we are going to be the people shaping this work, and we will likely be incubating various ideas to see what works best, as well as making sure that communities have a way of shaping the work themselves that may work best for New York State versus the Great Lakes region versus the West Coast, for example, and then we want to trade ideas. One idea that gets incubated in Washington State, for example, may be a fabulous idea for Michigan, or it may work really well in New York, or you may already be incubating something that's really successful. So we are at our infancy right now, and I know that NYSET will be involved, and I certainly know that Frederica took note of your interest in being involved as well, because we're going to need that.
This might go without saying, but don't forget your MD-DO colleagues when it comes to medical schools, because we're all a team effort, and this is going to take a team we're a team in healthcare, and this is going to take a team to fix this. And so when you branch out and talk about cultural competency in nursing school, you definitely need to talk about it in medical school, because I will tell you, I had one course for 3 hours in my time in my 4 years of medical school to address cultural competencies, and that clearly is not enough. And so we need to change the curriculum, not only also within medical schools, but then in residency programs. So you should get it again when you are in training, and then you should continue to get it when you're in attending, because people will forget it. And those are the people that are me, that are on the front lines, who end up forgetting what it is that they learned back in medical school, and go back to their implicit bias when they are seeing the the 100th patient that they're trying to see for the day.
That's excellent. Angelina, and then we'll go to the microphone down here.
And I just wanted to say, in regards to nurses or African Americans finishing nursing school, that's a topic that I am very endear about because when I graduated nursing school, I was one of 72 people, the only African American that graduated. When I started the program, it was a handful, a bunch of us, but they all end up, dropping out or something happened to where I was the only one that graduated. But when I went to the school, there was a number of African American students. But the practices to, I guess, enroll in the nursing program was very deceptive. If you didn't get a certain rate on the pre-admission test, you were informed to go to try the medical assistant program first, and then when you graduate from that, we'll put you in a nursing program. But those are two completely different programs, so then it becomes a money thing. So you want me to pay $60,000 for a nursing degree where I may not make it? So those type of practices is something I'm very endear about. Then on a community level, our community colleges, I know some of our members were instituting like resources for African American students to make it successfully through the program. So we're trying to address that problem and come up with programs or resources to help African Americans reach the goal line.
Thank you.
In Connecticut, and I was super blessed to be raised by a woman who did not instill in me racism. I definitely believe that any ism is something that is learned and not nature. I've been a mother, I'm a grandmother. I don't see that from birth. You don't see that, and I think so education to me is huge because education, I'm not saying that every person who's raised in a racism house comes out to be a racist, but it definitely influences that. And education is really the only aspects we got to get into that, And one of the things I noticed going into nursing school, or even with cultural competency being kind of like a thing now, when they are teaching us things, they're teaching us things I don't think necessarily influence racism or not. Like they're teaching us that, Asians don't like to make eye contact, or Puerto Rican people like to have their whole family in there. I mean, that's not the information we need. We need to know this, that, black babies are twice likely to die. That's the statistic you need to give me, because I think in America, our levels of people's race and how they decide whether or not how they're going to act is so different, because you could be fresh from your homeland, and that's one degree, but then you could be born here and you're an American, you're raised in our school systems. You don't necessarily have all that, I'm not going to make eye contact with you stuff. How is that even helping me take care of you, Right, so I think is there something going on to help better these, even if they have a class, is the class even useful to help?
And is it normed to white women again?
Exactly. So,
You've othered everything.
Are we really learning what we need to learn to better take care of
You teed up so many things. It's like a whole list. I'll just start with the, there are other things beside cultural competency for sure. So what our organization, there are about 30 organizations that do specifically anti-racism trainings. I mean, I was blessed to be funded by the Kellogg Foundation, and we're doing truth, racial healing, and transformation. And so it starts with just some truth. So a lot of this language I did not learn in medical school. These are all things I've learned being a part of that process and going to, being a part of enough trainings to understand a different framework. And our education system teaches some basic racist ideas, right? And so even how we teach the history of this country is racist, And so even how we talk about cultural competency sometimes can be really painful for me. And I go into spaces and work with hospitals. I'm working in New York, I'm working in Michigan. I got to fly to Kalamazoo next week, working with hospitals around doing specific anti-racism work, which is not the same thing as cultural competency. I work usually with the cultural competency department because that's where you at least get a leeway and people are required to do the 3-hour online thing. But there is a love and a desire for folks to hear it in a more concrete, give me some facts beside Puerto Rican people like to have their family. Like those are such pejorative kind of language, honestly. And it was, so we're trying to get to some more truths.
Thank
you.
you.
It can, yeah. Right?
One of the things that
Yeah, I was going to say, let's jump in because I think I'd love all of you to respond to that and offer some closing sort of calls to action as you think of them.
So what I was going to say is that one phrase that I really like, I mean, cultural competency for me is like always been problematic.
Yeah.
In addition to the fact because it in many cases reinforces racism with some real horrible like stereotypes that are part of the curriculum, but also because, like if you're going to get surgery, do you want a competent surgeon or do you want the best surgeon, right? It's almost like a real lowering of expectations. You only have to be competent, not particularly good, which is why I really like the concept of cultural humility. And in the context of power dynamics, walking into a room understanding that you should be humble about your own culture and that there are things that you think that you grew up with in your school systems, in our, the mainstream society, that on the face don't seem racist, but really are when you unpack them, like meritocracy, for example, which is the biggest lie ever, that has been, it's an enormous lie. There is no meritocracy here because people come from, have different playing fields, and some people have accelerated pathways to things because they're men and because they're white. So thinking about how you enter, again, like with humility about who you are and what you're there to do, I think is it's something that you can do in daily practice that will help you really listen. And the other thing that I'd like to warn, especially in the medical community about, is this idea of the patient that does not, lack of adherence?
Non-compliance.
Non-compliance. Which is so loaded, right? It doesn't matter if the reason you didn't
come. Compliant. I know you're shocked by that.
I mean, other than but the fact that you don't know if the reason your patient now has a diabetic amputation, and it's so easy to say, well, you were non-compliant because you didn't do these 17 things that I told you to do, without knowing whether there's even the possibility in their home where they live to access those 17 things, right? I heard a very wise person once say that, you have communities that are living in post-traumatic stress without the post, right? And have developed strategies to deal with that dysfunction that then we say, well, you're just non-compliant. And so, it's being able to think about the whole coming in an attitude of humility, of listening, and of listening of what's happening not just in that physical body of the person, but in that family and in that community. And then working with partners like community health workers and people who can have a connection and a trust that maybe they're not ever going to have with you or with even the hospital because of the situation and centuries of being mistreated by institutions like that, then that way you can create a plan where you really are serving the communities that you are trying to serve, understanding your limitations in terms of who can provide what to what are, at the end of the day, are in many ways very traumatized communities who are trying to figure out how to keep things moving forward and not necessarily being obedient to this white-coated white God here in front of me who thinks he can tell me how to run my life and how to have my family.
Thank you.
So that is a very, very good point. But being on the front lines, unfortunately, it is hard to do that in the unlimited amount of time that you have to see a patient. And so that is a great segue to my point of healthcare. The way that we look at healthcare has to change. And it no longer needs to be looked at as a commodity, but as a right. And so when you're able to take out the money part of healthcare, you're able to do that because it's not, you're just seeing a patient for money, but you're seeing a patient because you really are trying to make a difference. All of us went into this because we're really trying to make a difference in life, but at the same time, we also have bills. And so it is hard to continue to do your life's work of taking care of somebody when you know that to be able to provide for your family, you need to see 30 patients in an hour as opposed to 15 to really, and be able to take time to see those 15 patients and really take the time to realize what is it beyond just your physical right now. How else can I help you as a whole, and how does that play into the treatment that I can give you? And so we really, really need to have a conversation about healthcare being no longer a commodity, and seeing it as a right for everybody, and that's how everybody can get better.
Thank you. Yeah. Angelina, do you want to offer us some closing thoughts from a member leader's perspective?
I just want to say, as a professional, we have an obligation to care for our patients, regardless of their social economic position. We have an obligation to care. And I feel as professionals, if you are in an environment or a community where you don't understand that the demographics, do some research. Understand, like I said, what the historical trauma is to that area you're working with. How have generations dealt with, let's say, the healthcare system or the education system or the legal system. It's our obligation to understand our patients to better treat the patients. If I have a patient coming in I don't know nothing about, I ask questions. Help me understand you so I can provide better care for you. So we just have to take that small amount of time to understand our patients and provide the best care as possible.
Thank you so much. What an excellent point to end on. All right, you have been also very generous with your time. Thank you for your comments and for your questions. Thank you for this time today. I really look forward to seeing how this work manifests itself in your locals and in your state unions, and I look forward to working shoulder to shoulder alongside you on this work. Thank you so much.
And for folks that are joining us for the Poor People's Campaign, we need to leave immediately. See the people in the blue scrubs right outside.
Thank you.